Shall we wait for 5 more minutes
Okay, Sandy.
until more people join us?
It's right.
So, shall we start now?
Yeah, sure.
Yes,
So, good evening, everyone. I warmly welcome you all to the volume 9 of the Surg Ahead for November. So, today the session is organized by the GI Surgeons Association. Thank you very much. And today we are privileged to have Dr. Amal Priyanka, most eminent GI surgeons here, and along with Dr. Isuru Upanishad, consultant GI surgeon, who is a moderator. The topic is management of anal fistulas. So, over to you, sir.
Can I go ahead?
Yes.
I'll go from here. I would like to thank College of Surgeons on behalf of Sri Lanka Society of Gastroenterology for inviting Dr. Amal Priyantha, our presenter today, and myself for the Surg Ahead 9th volume. And I would like to introduce the speaker today, who was my postgraduate trainer as well. And he's not new to any of us. He's Dr. T.J. Amal Priyantha, and currently he's a senior lecturer at Faculty of Medicine, University of Sabaragamuwa. This is after he finishing around 30 years of service at Ministry of Health, and he served in Kandy, Teaching Hospital Kandy, and Teaching Hospital Kaluboy. And he was a trainer of most of the current senior GI surgeons, including myself. And Dr. Amar Pianta received his MBBS from University of Ruhuna in 1993, and thereafter he completed MS training in Sri Lanka. There and for further training in gastroenterology, he was lucky enough to get trained in 3 countries. So firstly in Australia, and then in United Kingdom, where he attained his FRCS Edinburgh, and later in Japan in consecutive 2 occasions. Thereafter, he became once president of Sri Lanka College of Gastroenterology, and after he served as the secretary of Society of Medicine Kandy, and he was a council member of College of Surgeons. And he has many publications in national and international, and several orations as well. So it is over to you.
Okay, thank you, sir, for generous introduction. So I will straight away start. Anyway, I would like to thank again to College of Surgeons, President and the Council for giving us this opportunity. Right. So as you know, fistula is by definition epithelialized tract between 2 surfaces. It's an abdominal connection. In the case of anal fistula, the connection is between the anal canal and the perianal skin. The reported incidence vary between 10 to 30 per 100,000 per year, and it is second most anorectal disease following hemorrhoids. And males are more affected than females. That's worldwide. So it has a long history. Just briefly look at the history. It has been known for the humans for a long time. Even during Susuta's time, it was called the Bagandhara, a name which is familiar to us even today. I think Ayurvedic physician used this name. And in Hippocrates, he is the first person to recognize this as a clinical entity. Later on, the cryptoglandular theory for the origin of anorectal fistula and other anorectal septic condition was introduced by Eisenhammer and Parkes. So later on, it was classified according to Parkes' first fistula classification. So that's a brief history. And as I mentioned earlier, 90%, 90 to 95%, most of them are arising from the anal gland sepsis. So these are what is called the cryptoglandular theory. So that implies, as you know, there are a lot of anal glands, especially around the dentate line, and they have long necks. If one of these neck become blocked and get infected, then this infection can spread along the fascial lines, along these resistant pathways, and giving rise to various abscesses and fistula in different locations. So this theory is further strengthened by the fact that some people, at least 50% of the people, have a history of anorectal abscess and fistula developing following anorectal abscess. Then small percentage of anal fistula may be arising from the inflammatory bowel disease, especially Crohn's disease. Actually, 1 in 3 patients of CD is Crohn's disease. So it's supposed to have anal fistula, and it's very difficult condition to treat, and there are multiple. We in tropical countries seen tuberculosis as anal fistula. I have seen 1 or 2 cases myself. And then the other causes, rare causes, just to mention, fistula following trauma, irradiation, and cancer, etc. So I don't need to go into the detail of the anal canal anatomy, but one fact I want to highlight is the location of the dentate line. That is a very important anatomical structure for we surgeons, because as you will see, most of the internal opening of the anal fistula located in and around this anal, the dentate line. So how do you locate this? There are various different theories. The most accepted theory is it's located in between the deep and subcutaneous part of the internal anal sphincter, as you can see here. Others define it as a junction between upper 1/3 and the lower 2/3 of the anal canal, which is anal canal is about 2 to 5 centimeters long and longer in males rather than females. And still others locate it as about 2 to 3 centimeters from the anal verge. So those are the different definition of the anal, the dentate line. So there are a number of classifications introduced to classify the anal rectal fistula. We all are familiar with Park's classifications. The original Park classification had actually the classification is based on the relation to sphincter complex. So original Park classification had 4 types of fistulae, and later on there were various subtypes that were added. On the other hand, St. James University Hospital classification is actually introduced by the radiologists following the introduction of MRI. So I will show you the comparison later. And still later, there was another classification called the Gregg classification. Gregg, actually, this comes from India. So actually, this is very useful because they classify according to the Gregg classification, we can identify the complex and simple fistula. That distinction is important for us when we are managing anal fistula, as you will see later. So that's why it is very useful in that way. So this is the comparison I was talking about. So basically in St. James University classification, intersphincteric and transsphincteric fistula are divided into 2 groups. That is the linear tracts and multiple tracts. If you look at the Gregg classification, type 1 and type 2 are simple fistulae. So type 1 is actually transsphincteric or low transsphincteric or intersphincteric fistula with only single tract. And the type 2 is low transsphincteric or high intersphincteric with multiple tracts. So both are classified as simple fistula, and rest are classified as complex fistula. So how do you define? So there are various definitions. We should know the definition. The low fistula is applied when there is a sphincter involvement less than 30% of the sphincter complex, and above that is called the high anal sphincter fistula. And according to the American Society of Colorectal Surgeons, a simple fistula is defined as intersphincteric fistula and low transsphincteric fistula, that is less than 30% of the involvement of the sphincter complex. The rest are complex fistula, involvement of sphincter complex more than 30%, suprasphincteric, etc. All the other high fistula. Then there are a few other definitions apart from that. So some people classify any complex any fistula with multiple tracts arising from Crohn's disease, radiation, recurrent fistula, etc., because they are usually associated with multiple comorbidities. Another definition define the complex fistula as a fistula that can be treated with fistulotomy without high risk of incontinence, and vice versa. But this is not very useful because after all, we have to see whether it is complex or not before surgery, not after surgery. Right. Diagnosis is very straightforward. They can present as acute stage like perianal abscesses without any history of abscesses, chronic presentation. Patient usually comes with discharge or sometimes pain or itching. Some people may give history of drainage of abscess few months ago. And perianal examination is mandatory to recognize the number and position of the fistula, external opening. Right, especially position, we record the position according to the clockwise position. And you might see some scars in case of recurrent the repeat surgery. So it is important to recognize those scars and where they are located, as well as any deformity in the perineal body related to multiple surgical procedures. Then digital rectal examination is an integral part. Here it's very important to record the anal tone, because if you especially dealing with the poor anal tone, then the patient may have overt sort of incontinence, right? So patient may attribute that might become even more little weaker later with the fistula surgery, and you might end up in a problem if the patient comes with incontinence. So recording anal tone is very important, especially repeated surgery, because prior surgery might have already damaged the anal sphincter. So you got to record this very carefully. Then if you are lucky, you can palpate the internal opening. Sorry, about 20 to 25% patients, you can palpate the internal opening. So you can actually go into more detail during surgery, because you are undertaking examination under anesthesia. It is more comfortable to the patient. And at this stage, some people recommend two-finger digital examination, because sometimes you can feel the fistula tract as a thick cone. So that is very useful when you locate the internal fistula. So imaging techniques are actually fistulography is now we are not doing it anymore, because the main drawback of fistulography is that you cannot actually locate the fistula in relation to the sphincter complex. That's the main drawback. So MRI is considered as a gold standard. Not in all cases. Actually, American Society of Proctology, they recommend MRI, especially if you think this patient is going to be complex fistula or even recurrent fistula after surgery. CT is not much helpful, but can be of some help, especially if the MRI is contraindicated, or if it is not available, like in our case like that. So endosonography has shown comparable results to MRI, but unfortunately, a lot of people do not have technical expertise to do this, especially linear endoscopy. So when you take the MRI, it's very high sensitivity, and it has very high sensitivity as well as specificity. But sensitivity and specificity differ in different component of the fistula. So for example, sensitivity for the fistula tract is not same as the abscess cavities or inflammation. Therefore, usually they recommend different MRI protocol for this subgroup of components in the anal fistula, because that is an integral part of assessment of the anal fistula. So this is the usual picture. This is normal anatomy of the MRI. This is axial imaging. You can clearly see the internal, the intersphincteric space, which is very important for us to deal with, especially the classified anal fistula. And this is the coronal imaging again. You can see the nicely coronal image of the sphincter complex as well as the intersphincteric fistula. So that is very important for us to classify the fistula in order to take appropriate surgical surgery. So when you look at MRI, these are the features we are looking for. As I mentioned earlier, first and foremost, the type of fistula. Then the location and the number of internal openings. Sometimes you can have multiple openings, and especially whether you can detect the internal opening or not. Sometimes you can't detect this. So that is another very important finding. Then with regard to the fistula tract, whether they are single or multiple, and the length and depth and everything, and also the activity of the fistula tract, right? If it is not active and it's fibrous, you may have difficulty in finding to pass the probe. Then other features like abscesses, etc., and extension, all that can be again this from MRI imaging. However, there are certain drawbacks. The main drawback I would say is the inability to locate the dentate line in MRI imaging. This is very important for us because, as I mentioned earlier, internal opening is most likely to be located in and around dentate line. And for us, it is not available always. In my unit, only about 5 to 10% of the patient were able to get MRI done. So the rest we had to go ahead without MRI. So that's the main difficulty for us. It is said to be little time consuming compared to US, but some people may not tolerate it. Cost is a factor for us. So this is the cost comparison. Even in United States, MRI costs 2 to 3 times more than the US. So India, as same as Sri Lanka, it's I think our cost is for US and MRI is the same. But in India, of course, US more popular because there are so many people who are competent in doing this with linear ultrasound. Right. So the most important aspect is how to undertake treatment for anal rectal fistula. So what we have to remember is the two main goals for the fistula treatment surgery. That is to achieve the complete healing of the fistula tract while preserving the anal sphincter function. These two has to be stick to. Then there is an array of treatment modalities, including surgery. Now, surgery can be divided into two main groups, sphincter cutting and sphincter preserving. Now, this is a 20-year literature survey. It shows, despite its drawbacks, surgical treatment, especially fistulotomy, fistulectomy, remains the most popular method of treatment. And of course, the lift procedure is catching up. And the rest of all the other procedures, non-surgical procedures, account for about 10% of the procedures done by the surgeons. So let's first look at the sphincter cutting procedures briefly. This entails fistulotomy, fistulectomy, Seton insertion, and you may combine fistulotomy with Seton sometimes. And there is another technique called the fistulotomy with primary repair of the anal sphincter, sphincteroplasty. So fistulotomy still regarded as the gold standard for treatment of fistula, in spite of its drawback, namely the problem with the continence. So actually what we do is we lay open the fistula tract along with the sphincter below the sphincter, the fistula tract. It has very high, it's supposed to have very high fistula cure rate, about 95%, but the range may vary depending on the expertise, 74 to 100%. One of the main issues in fistula surgery is to assess how to assess the impairment of continence, right? So it may be frank total incontinence, or it may be continence for liquids or flatus, or just maybe soiling. So because of that, if you look at the literature, the continence rate vary depending on the definition. Anyway, it is reported that about 1 in 3 patients may be having some sort of incontinence after fistulotomy, right? But the range vary from 0 to 45%. So how to prevent the incontinence? First, the most important thing, you must never touch the anorectal ring, right? If you divide anorectal ring, you will end up in total incontinence. Then anyway, most of these procedures will damage or cut some degree of sphincter complex. So what you have to remember is greater the sphincter division, higher the impairment of continuous. So that's the rule. So you have to remember. So try and minimize the damage to anal sphincter complex. So compared to fistulotomy, actually there is not much of difference as far as the railing rates are concerned, but fistulectomy is slightly more technically demanding. Besides, it is inferior to low-lying fistula, less effective. Actually, though it is minor in nature, fistulotomy has some certain advantages in terms of short operating time, reduce hospital stay, less post-operative pain, etc. And contrary to the belief, fistulectomy, especially for higher fistula, carries a higher risk of sphincter damage than incontinence. Therefore, fistulotomy remains the most preferable option, especially for low-lying fistula. So what about the seton? There are different types of seton. It may be loose seton, cutting seton, or draining seton. Loose seton, you don't tie the knot. In cutting seton, you tie it around the sphincter complex. And draining seton is only meant for drainage of the abscess cavities and sepsis. And this is actually a palliative method for patients with severe symptoms with incurable or even associated with Crohn's disease, etc., with problem with continence. So a survey shows 90% of the surgeons prefer application of the loose seton, and some 30% of the surgeons apply cutting seton. That means about some people may apply both things. And 6% of the surgeons never opt for seton application of seton. So the principle of cutting seton is that it slowly divides the sphincter muscle while inducing fibrosis around the sphincter. So it will never at any given time, the sphincter is not laid open. So that's the theory behind. So it is indicated in some high and complex fistulae. The material used are different, but if you use a stretchable material, you only have to apply seton only once because it gradually cuts through. But if you choose a rigid material, you have to repeatedly tighten it. So healing rate is reported to be between 80 to 100%, and continence rate very widely vary. Actually, this continence rate depends on, they have shown it depends on the interval between the tightening of the cutting seton. If you apply too short interval, like once or twice, 2 weeks, then there is hardly any time for sphincter to heal. So because of that, they can carry a higher incontinence rate. So what is recommended is more than 3 weeks, not too long, at least after 3 weeks. So by that time, there is enough time for the cut portion to be healed. So anyway, it carries some degree of incontinence, though it is meant not to be. So therefore, you have to warn the patient regarding the possibility of incontinence. So actually, again, the healing rate depends on the length of the seton that you apply around the sphincter complex. So there are different material that are being used as seton material. The most popular material is the silicone loop, but we use silk because we think it is less uncomfortable to the patient. It is cheaper also. It's readily available. And some people use proline and variety of techniques. Some people, one person has used electrical cables as well. If you are contemplating a loose seton, then ethibond is good enough. So let me just show you, there are various techniques for applying seton. Now in this first thing, what you do is you cut this part, subcutaneous and cutaneous tissue, and then apply the seton around the entire sphincter complex, including the going through the fistulous tract. So that is the first technique. Then there is another technique where First, what you do is you do internal sphincter order. You cut, divide the mucosa and the internal opening, internal sphincter, and then apply the seton around the external sphincter complex, right? So that's the second technique. And the third technique is called the pulling seton, where you cut the internal sphincter, divide up to the internal sphincter mucosa, and you deal with the external part of the fistulous tract. You do fistulotomy, right? Then apply the seton. So you are applying the seton only around the external sphincter complex. So that's this thing. Actually, we use modified techniques. We don't divide anything internally. We divide we do the fistulotomy, the external part of the sphincter, external to the sphincter, we lay upon the tract, and then we apply the seton around that after making a subcutaneous incision. So that is our technique, slightly different from that. So there are various modifications for that. Some people will suture the divided sphincter, internally sphincter after trimming the edges. Others will use a loose seton or even tight seton. Those are the modification to the above three techniques. Then, in order to address this incontinence problem, some people for high fistula, they have laid open the high fistula tract and undertake the repair of the internal the sphincter complex at the same time. But there are only limited studies, and this evidence is not good enough to put it into the practice. So anyway, that's one method that has been used. Then we have sphincter saving procedures because of this problem of incontinence and etc. People try to avoid cutting or damaging any part of the sphincter complex. So lift, all of us know, it's one of the reason and most popular thing. Here, what you do is we divide the fistula tract through the intersphincteric space, right, between the internal and external sphincter. So it is safe and cost effective, and results are encouraging. They have achieved very good results. The most important thing is here, if you can see, the incontinence rate is very low, 1.4. That is the main advantage of this. But this is not without problems, right? Sometimes when you dissect the intersphincteric space, you might form the hematoma, which may in turn get infected, and you might have a recurrent fistula. That is, you have to remember. So you have to be very careful when you dissect in intersphincteric space. Then Tropis procedure, recently introduced procedure. Here the principle is now here the principle is to get rid of all the sepsis, right? Especially up to the internal opening, and allow it to heal by secondary intention, by fibrosis. So that sounds very attractive, because the problem here is we are most of the time we are unable to deal with the internal opening properly. So the theory is, if you close the internal opening properly, and if you allow it to heal by fibrosis, the fistula will heal. So this is how they do it. You introduce artery forceps into the transanally into the internal opening, and go into the internal sphincteric space and divide the internal sphincter with the mucosa, and lay open this tract so that it will heal by fibrosis, right? So the lateral part of the fistula, that is the external part, you can deal with either way. You can either curatize or put a seton or whatever it is. Anyway, here the principle is, if you deal with the internal opening properly, fistula is most likely to heal, and it will not amount to much of an incontinence because you don't touch anything to the external sphincter complex. So that's the advantage of that. Anyway, we don't have much literature on that. Then you have various advancement flaps, right, designed especially to the patients with difficult anatomy, right, where especially if you think hysterectomy might carry a higher risk of incontinence, and also in things like Crohn's disease, etc. So reported success rate varies between 50 to 60, and they are still there is incontinence rate, right? So the main principle is you must ensure adequate vascularity of the flap, and you have to bring it as tension-free anastomosis or suture, and you have to cover the entire internal opening. So sorry, right. So you can do as either, usually it's a local flap, you use a flap either inverted or U-shape, right? But there are certain surgeons who does of flap, right? That means you like Delorme's operation, you dissect a sleeve of mucosa and bring it down and anastomosis. So that will ensure the covering of the internal opening. So you can do the reverse also. Instead of bringing from up, you can bring the flap from bottom, from the enodermal, right? So enodermal advanced flap, the success is similar to the mucosal flap. However, advantage is that if there is stricturing of the anal canal due to multiple surgeries, you can deal with at the same time by dermal advancement flap. You can enlarge the anal orifice. So then you have rectal advancement. So you bring it from the rectum, right? So for complex fistulae, right? Here again, the principle is the same. Success rate varies. But one thing I must want to highlight is the recurrence and the incontinence depend on the thickness of the flap you employ. If you apply full thickness flap, the recurrence rate is less. However, incontinence rate goes up, and vice versa. If you employ mucosal flap, the recurrence rate is high, incontinence rate is low. So that is the inverse relationship. So you have to balance between the two when you are using a rectal advance of flap. Then how to the recurrence? Word about the recurrence. It's the most difficult issue to address. The reported recurrence rate vary in the literature from 2.5 to 57.1 across the literature. So what are the risk factors for recurrence? First thing is actually, of course, the fistula anatomy. Complex fistula, as I mentioned earlier, carries a high risk of recurrence. And other important things, the non-detected internal opening, which I am going to deal in more detail in a moment. So non-detected internal opening. Then there are factors related to surgery. If you have prior surgery, then you run a high risk of recurrence, and also depends on the selection of your procedure. As I mentioned already, I have already dealt with that. So it all depends on your surgical techniques. And another factor is associated comorbidities. As I already mentioned, inflammatory bowel disease, irradiation, etc., carries a very high risk of recurrence after fistula surgery. So I'm mainly dealing with the cryptoglandular fistula. So recurrence rate for various procedures, overall recurrence rate about 18%. And to deal with recurrence, you might need up to 3 different procedures, right, to achieve the healing. So these are small study. They dealt with various type of fistula using different techniques, interspictoric, transpictoric, highspictoric, etc., using different techniques. However, the numbers are small, so we cannot actually draw any conclusion from that. So how do you reduce the recurrence rate? If you use MRI, that has been shown definitely can bring down the recurrence rate, right? So they have estimated if you do without MRI, the recurrence rate may be as high as 52%. Whereas if you have MRI, you can bring it down to about 13%. So that means even with MRI, there is a certain percent of recurrence that you have to remember. Then I already mentioned identifying the internal opening is the prime important thing. So that is, I consider this as a very, very important step in surgery, fistula surgery. If you don't identify the internal opening, then you are in trouble. And then your procedure choice. And if you cannot handle, please refer to an expert. So how are you going to locate the internal openings? If you are lucky, you can palpate this as an elevation, 5 process fit or soft granulation tissue, etc. And actually, you have to probe this. If you want to do fistulotomy, you have to put a probe. So when you are inserting a probe, you have to be very careful that you make sure that you don't make a false track, right? But you might encounter difficulty, especially if there is a fibrous tract or if there are acute pains. So it's difficult probing. Anyway, so if you can't do probing, what are you going to do? Right. Some people, well, this is very controversial point. Some people say you probe from the internal side at the most possible location, because after all you cannot still locate the fistula, but that's a bit of controversy. Other option is to lay open the tract in piecemeal from starting from the external opening, put the probe, you lay open the length where you have put the probe, and then you can identify the distal opening later on. You can keep on probing and lay open the tract piece by piece. So that is one method. Second method is, if you can't do that, then you resort to fistulectomy, right? So when you pull out the fistula and exert some pressure, pull it outside, then you might straighten some of this curved tract. So that's the theory behind of this method. So then you might be able to pass a fistula probe. So that's the theory behind. Then other tract, if you can't do anything, then you can use injectable preparation. Hydrogen peroxide is preferable to methylene blue, because methylene blue causes a lot of tissue staining, and then you can't identify the sphincters, etc. And we still use Goodsall's law to locate this, especially because we don't have MRI in most of the case. So let's look at the Goodsall's law. So it states that if you have anterior located fistulas opening, anterior to the horizontal line, their internal opening lies in the corresponding area, right? On the other hand, if you have posterior fistula, then most likely your opening is at the midline, 6 o'clock position. But there are pitfalls. You can have internal opening in the anterior located, but it's still arising from the posterior. So that's the bit of a pitfall. So you have to be very careful. So accuracy of the Goodsall's law is around 75 to 78%. This is Professor Nandadeva's study published in CMJ. But you cannot 100% rely on this tip, but you can use this as a guide only, right? So people have analyzed the usefulness of Goodsall's law, and it shows it is more accurate for posterior located. There are two factors that determine the success of Goodsall's law. One is the location, posterior location. Second one is the length of the fistula tract. So it is more accurate for posterior place, short and fistula, especially less than 3 centimeters tract, right? So having done all this, still, if you can't still identify the internal opening, then you call it a non-locatable internal opening. That can happen in spite of having MRI. It has been shown up to about 10 to 25% of the patient may not have you cannot locate the internal opening, right? So the problem is, if you have non-locatable internal opening, then of course the recurrence rate is very, very high. So how are you going to deal with this problem? So there is what is called the Greg protocol, right? So you, as I mentioned earlier, you do all the possible method. You use all the possible methods to try and locate the internal opening, but still you may fail, right? Now, sorry. Now, if during after all this clinical examination, intraoperative examination, and intraoperative injection, if you don't have MRI, please don't proceed. You come back and do a MRI, some or the other. So that's the message. So if you have the MRI, and MRI also cannot sometimes locate the internal opening accurately. That has been shown. So what are you going to do? There are two principles where you can guide the internal opening or location of the internal opening. One is actually extension of the Good-Charles law. In case of posterior midline, it is most likely to be located in the 6 o'clock position. But otherwise, you can go through the MRI report very carefully and check where the track ends internally, right? It may not accurately show the internal opening, but it is ending somewhere around submucosal area. So you consider this as the internal opening and go ahead with the fistula. So that's the last thing you can do. Otherwise, you cannot operate this. So this is a great protocol which is being widely used, and some people have done a lot of studies on that. So so those are the surgical procedures. Then of course we have non-surgical procedures like fibrin glue. Here what we do is we curate the fistula tract and fill with fibrin glue, right? Curate is around 10 to 70%. It is well tolerated because it's not painful, no risk of incontinence. And of course, if you want to resort to another method for surgery, for example, you can do that also. But only the evidence are lacking. So that's the main disadvantage. We don't know exactly what is the accurate success rate and incontinence rate, etc. Fistula plug, again, the principle is you fill the fistula tract with matrix, some sort of matrix. So the body will induce fibrosis and heal the fistula. So it's a simple procedure, but it's very expensive, I heard. Healing rate varies, average about 54%. But given the risk of incontinence, this is fairly acceptable. You don't do it for each and every patient, right? So we can consider this in a patient in whom the other procedures may carry high risk of incontinence. Here again, the evidence is not not strong enough to practice this routinely. So it is reserved for very few patients. You have to select the case by case. Then minimally accessed procedures, video assisted anal fistula. And here what we do is we visualize the entire fistula tract along with the side branches, the abscess cavities, etc. And then it is curetized with monopolar diathermy, and the internal opening is closed, right? It has been shown to have high success rate and low impairment of incontinence. But my question is, now if you can pass a scope into the fistula tract, you might as well do surgery, because most of the time our problem is not to pass the fistulas, the video, but to locate the internal opening. That's the main problem. So if you can locate this, you don't need any of these things. So that's what I think. So anyway, we need this expensive gadgetry for that. I don't think it is feasible for us. Similarly, laser treatment, it was very popular once, but nowadays it has been shown its success rate very low, right? So there are three methods: fistula tract laser closure, fistula ablation, and fistula excision. Different methods. None of these have so far shown any promising results, unfortunately, despite the cost. Then another endoscopic method, fistula application of fistula clip. So this is extension from the upper GI therapeutic this thing, but it's mainly reserved for anterior fistula in females, especially like rectogenal, rectourethral fistula, etc. But in case of anal fistula, I don't know, it may be very uncomfortable to apply clip and keep it inside the anal canal because that's the main concern. Anyway, it has not been approved by the FDA so far. It can fail if there is tip migration and abscess formation. Then the most recent thing is stem cell therapy. So this has shown to be very effective, but there are concerns, especially regarding the safety profile, and it involves very high cost, as mentioned. It may be very small percentage of patients like complex fistula and high degree of high chance of getting incontinence. This may be suitable in some patients. So what about the place of stoma or fecal diversion? I have seen some patients come with stoma, but there is a very, you have to understand, there is a very limited place for diversion. If you have a patient with very large fistula tract, right, with significant symptoms disturbing their lifestyle, then you might consider this in patients, especially with other comorbidities like irradiated pelvis, Crohn's disease, etc. Right? Some people I have seen doing this after advancement flap. That is not actually recommended usually. So again, finally, the concern about the malignant transformation. It is rare, but has been reported. But only there are only few case records. So that means you don't have large studies. Means it's very rare. You don't have large collection. However, the recommendation is you have to send the fistula tract for histological analysis. Not always, but especially long-standing fistula, etc. So you might occasionally come across fistula either originating from the fistula, or it may be secondary fistula, secondary to some sort of malignancy. So in conclusion, ladies and gentlemen, complex fistula is poses a lot of challenges, and you got to recognize these challenges and tailor your treatment based on your experience and knowledge. So thank you for patient hearing.
Okay, thank you very much, Dr. Amar Priyantha, for that comprehensive and informative presentation. Now it's open for discussion or any questions. If you have any questions, you can either send through chat or can ask directly. Sir, can you hear me?
Yes, yes, sure.
So have you used ever this platelet-rich plasma therapy for
that has been described. Yes, I didn't include that. That has been described, but it's not. Again, the experience is very limited. I know that's an option, so we can't recommend like most of these other non-surgical options. Though it has been limited to very few case studies, so I cannot actually recommend that. So that's what I have to say.
Actually, I went through the recommendations. What you was telling was absolutely true. However, because this it is not so costly, and for the patients, because these machines are available in most of the hospitals. So at the moment, it is recommended only for non-complex fistulas. But for these non-complex fistulas, we can have better results, I think, with the surgical management as well.
Yeah.
So
if you have a fistula which is more complex, and if you think that it carries very high risk of, after multiple surgeries, carries very high risk of recurrence and also incontinence, you might give a try because nothing is lost, no?
Yeah.
Because you can, if you want, you can do another surgery later because you are not dealing with, you're cutting anything.
And sir, for the complex fistulas,
Yeah.
complex and prolonged fistulas in IBD patients,
Yes.
we use infliximab. How's your experience on that with the symptoms?
Very dismal. I had couple of patients. I don't know whether it is something to do with the drug itself or the application itself, but none of these people have been cured in my experience. Because I mean, after all, they were very extensive fistulae. I believe in, I have treated them. There is one or two patients of mine who had multiple fistulae, very intractable disease, and they have had full course of infliximab. They are back to square one. So what I did was I put them back on as a therapy after steroid therapy, and they occasionally get relapses, but it's being under control to a certain extent. Yeah. So
I think, sir, Chaturanga. So
Yes,
this
yes.
regarding this complex like Crohn's fistula, they have to first, I think, we lay open all the tracks. Whatever the tracks we need to lay open and then give the infliximab. Otherwise, generally anyway, we have to exclude any infection when we give
Yeah, true.
infliximab.
Yeah.
But the results are much always better. Whatever the possible track should be, all the tracks should be open, and after that, infliximab will work better.
Then it's a question of how we are going to. I mean, actually, what is the principle in dealing with Crohn's disease? You do minimal interference because the fistula tracts are sometimes multiple, very high. It will end up in incontinence, and also and the healing rates are very poor. What about putting a draining seton and then giving inflection? I think that's a better option because draining seton definitely will get rid of, if you put it properly, you will get rid of the sepsis.
Yeah, that
So
was that
I
is
think
the method which I have used, but it has worked for me about 10 to 20 patients. It worked actually well.
yeah. So that we can consider, yes.
And so there's a question from audience,
Yes, yes,
and one asks, while in search of internal opening with the probe,
yes.
if by accident, if the probing causes false tracking, how to
Mhm.
manage it?
Oh, so, I haven't come across that problem actually. That's interesting. Well, it depends on it's like this. It depends on. I mean, there is no. I mean, I haven't come across anything like the literature. But what my advice is based on my experience. Now, if you while you are probing, right? If you have made this accident, because at any cost you have to prevent the force track. But accidentally, if you have probe after coming very close to the internal opening, then you go ahead with the hysterotomy. That's the rational thing to do, right? Or you do put a seton and come out, right? So because if there is a little bit of chance that you have hit the acute the spot, but it may not be. Also, we never know. So if it is a low fistula, probably you might open up the tract and come back. But if it's a high fistula, then better not. I think if you don't have MRI, don't proceed. That's my advice. If it's a high fistula, come back and do MRI. For low fistula, you might be able to end up by get away by doing a fistula. So, but if it's a high fistula, if you think, I think you come back and do MRI. If you don't, if you have MRI, then the question is much easier.
Okay, sir. So in the absence of further questions, I think it had been a comprehensive session regarding the perianal fistula. And thank you very much, Amarpyantha sir. And I would like to further thank College of Surgeons for organizing this session. And we had over 50 participants. It's a big number. Actually, I think all of them will benefit from this much of informative and presentation, which is of a very high quality. So thank you everybody for participation. Thank you, College of Surgeons, and thank you very much again for this
Okay,
excellent
welcome.
lecture.
Welcome.